Good afternoon, and welcome to the Radiation Oncology webinar series focusing on Ewing sarcoma. I'm Iga, your host for today's session. First, a big welcome to our speaker, Dr. Gerd Jensen. It's truly an honor to have you share your expertise with us today. We are also excited to have Dr. Yuni Arta and Dr. Bambang joining us as panelists. Welcome, Doctor. We can wait to hear your valuable experience on today's discussion. Also, welcome to our moderator, Dr. Torana. Thank you for guiding us through today's session. We'd like to extend our sincere thanks to our audience today. Please don't hesitate to send your question to the chat box. And also, don't forget to register on Pelataran Sehat to access the FK-KMK. Today, we will dive into the latest research, treatment option, and field advancement for Ewing sarcoma. Before we begin our discussion, let's capture this moment with a quick photo session. Please open your video and don't forget to smile. Dr. Hannah, can you help me with our photo session?
Okay, wait a minute.
Okay, let me help. Okay, I will take a photo. 3, 2, 1, and smile. Everybody, please smile because we don't know which page you are on. Next page. Okay, thank you very much.
Okay, thank you, Dr. Vincent. Without further delay, it's time to hand over the session to our moderator, Dr. Torana.
I'm sorry, it seems like there is a technical issue. Let me help first.
Okay, can everybody hear my voice? Is it clear enough?
It's
Okay,
clear,
good.
Doctor.
Yes.
Okay, thank you. Sorry for a bit technical difficulties. Okay, good afternoon, everyone, and welcome to this exciting and informative webinar on radiation oncology with a focus on Ewing sarcoma. It is a privilege to have you all here to explore this. This is a rare disease, but it is a critical topic in pediatric oncology. It is a challenging disease requiring combination of surgery, chemotherapy, and radiation therapy for optimal management. Radiation oncology is also particularly vital in cases where surgical options are limited and playing a crucial role in improving outcomes and quality of life for patients. We are honored to have an incredible line of experts joining us today. Our keynote speaker is Dr. Geert Janssen from University Medical Center Utrecht, radiation oncologist and researcher for Ewing sarcoma. Good morning, Dr. Janssen. Can you hear my voice? Hello, Dr. Johnson. It is a pleasure to have you with us today. How are you doing? Okay, Dr.
Yeah. Now I can speak. Sorry, I was unmuted by the organization or so.
Oh, okay. Sorry.
No problem.
You can already hear me, and we already hear your voice. Thank you. How are you doing in Utrecht? It is still morning, right?
Sorry, sorry, I'm a little bit. They called me, but can you repeat your question? Sorry.
Yes, how are you doing? Is it still morning there in Utrecht?
Yeah, it's 10:15 in the meantime. So I have prepared the presentation. I think it will take around 45 minutes. And then we have time for discussion or so.
Great, wonderful. We are truly honored to have you join us. Okay, we also have two esteemed panelists in our discussion. The first is Dr. Yuni Arta Prabowo Putra. Hello, Dr. Arta, can you hear me? Dr. Arta? Dr. Arta is orthopedic oncologist from Sarjito General Hospital. And also Dr. Bambang Ardianto, Dr. Ari, can you hear my voice? Dr. Ari is pediatric hemato-oncologist also from Sarjito General Hospital.
Hello, Dr. Grid. Hello, Dr. Grid. I'm Arta from Orthopedy. Good afternoon or good morning.
Thank you, Dr. Arta. Okay, together our speaker and panelists will offer a comprehensive view of the challenges, advancement, and future direction of Ewing sarcoma. Thank you for being here, all the participants, and I encourage you to engage active, ask questions, or share your perspective throughout the session. Now let us begin by welcoming our keynote speaker, Dr. Jansen. Please, Dr. Jansen, the floor is yours.
Thank you for the introduction. Can you see my slides? Can you see my slides?
Not yet, Doctor.
Not yet. Then I will share again.
Yeah,
can you see it now?
Yes, we can see it now.
So, well, I'm a pediatric radiation oncologist. I work at the UMC Utrecht, and this UMC Utrecht is closely linked to the Princess Maxima Center. And the Princess Maxima Center is the National Cancer Institute for children. So this means that all pediatric cases are treated here in Utrecht in this new building. Well, it looks new, but in the meantime, it dates back from 2018. So this means in practice, we see around 15 sarcoma cases, Ewing sarcoma cases annually in children between, let's say, the age of 0 and 18. And in addition, of course, we have the adult sarcomas and the adult Ewing sarcomas, but they are not centralized. So they are spread over the Netherlands and treated in a couple of centers. Okay. So to our residents, I always say it's important, even if you are not a pediatric radiation oncologist, to know how to treat Ewing sarcomas, because if you see here the age distribution, also in children or in young adults, Ewing sarcomas do occur. And I think this is also for you a very interesting paper. It dates back already to 2000, but it's a very nice paper also describing the prognostic factors. In an interactive session with the residents, I always ask them, can you link the X-ray with pathology? And then, of course, those who are not familiar, they have some problems or they cannot explain it. But in fact, you have image 1 correlates with pathology image A, and 2 with B, of course. And I think these images nicely describe the difference between the most frequent occurring sarcomas. So image 1 is a Ewing sarcoma, image 2 is an osteosarcoma. And a Ewing sarcoma is a small blue round cell tumor. That's what you can see in the picture in the right upper corner. And you can see that an Ewing sarcoma is located, in general, in the diaphysis. And you have the typical onion peel, so the different layers, periosteal reaction. And in the osteosarcomas, you see the typical sunray image with calcifications. And here on the X-ray, you have the Cotman triangle. And the osteosarcomas are mainly located in the epiphysis area. So that's, I think, some background information that you have to know the main differences between an osteosarcoma and a Ewing sarcoma, because they tend to occur around at the same age. So here are some general facts now on Ewing sarcomas. So Ewing sarcomas, they can arise in the soft tissues as well. Most Ewing sarcomas are located, or the origin is in the bone, but they can also originate from the soft tissues. In the Netherlands, at least, we have an incidence, an annual incidence of roughly 1 new Ewing sarcoma per 1 million people. So this corresponds to around 15 pediatric cases. But you can see Caucasians have a higher incidence than Asians. So maybe in your country it's a little bit less, but at least I expect 250 new cases. In Indonesia, Ewing sarcoma is a systemic disease. So this means you always have to perform an MRI, of course, of the primary tumor, but also a PET-CT scan when available. And if not, then you have to do a bone scan, bone marrow aspirates, or a bone biopsy. At staging, 25% of the Ewing sarcomas, they present with metastasis. And if you treat Ewing sarcomas only locally, then 90% of the patients will die from distant metastasis. That's what we know from the old eras. And typically, they have a translocation. This results in an Ewing sarcoma FLI1 product. So 85% of the patients, they have this translocation, and the other 10%, they have the ERG translocation. And for patients without metastasis, the disease-free survival is around 70% with the multimodal treatment, of course. And patients with metastasis, they have a disease-free survival around 20%. And here you see the numbers of patients we had in 2023. And you can see the number is in the same range as the rhabdomyosarcomas. So we had last year 12 new Ewing sarcomas undergoing radiotherapy, because not all the Ewing sarcomas, they get radiotherapy at the end. So again, the same publication from Cotterill from 2000, as I said, an interesting publication, in data from almost 1,000 patients with Ewing sarcoma arising from the bone. You can see that top location is the pelvis, 25%. You have the ribs and the femur. And yeah, of course, you can have a Ewing sarcoma in all the bony structures, but these are the dominant sites. Now I go with you through the prognostic factors. The most important prognostic factor is the presence of metastasis at diagnosis. As you can see, with metastasis, the prognosis is good. Is significantly lower than without metastasis. But also the tumor site is a prognostic factor. Tumors of the extremities do better than the actual tumors, and there are several reasons for that. because you cannot give optimal radiotherapy. It's sometimes not resectable. Pelvic lesions are in volume bigger than tumors in the extremities, so it's a mix of other interrelated factors. So also the site in cases with metastasis. If you have lung metastasis only, your prognosis is better than with lung and bone metastasis. That's what you can see here.
Yeah.
So age is also a prognostic factor. In general, we take 14 years as a cutoff. Patients younger than 14 do better than older patients. And then here you can see the tumor volume is also a prognostic factor, and the response to induction chemotherapy is important. So for instance here, small tumors do better than larger tumors, and a large tumor with a good response is in fact better than a small tumor with a poor response. So around 2000, people were also convinced that the translocation factor, FLI1, was a prognostic factor. But 10 years later, the analysis was done. They looked at the different translocations, and at the end it turned out that the translocation at the end had not any prognostic impact. So I think the prognostic factors are important because the therapy is based on all these prognostic factors. And I think for you, it's good to realize that the chemotherapy used is always doxorubicin or ifosfamide, actinomycin, cyclophosphamide, vincristine, and busulfan-melphalan. So the current therapy is still based on these drugs already dating back from the 70s and the 80s. So my focus will be on the European trials because in parallel there were also trials done by the Children's Oncology Group and by major US centers. But my focus here will be on the European approach. So since the 90s, we have performed several international trials. And in fact, it's always the same pattern. You have the induction chemotherapy, the moment of surgery or radiotherapy, then the consolidation phase, and currently in the most recent trial, there's also a maintenance phase. But in general, for you, what you have to remember from the studies done in the past, there's an induction and a consolidation phase, and then the local treatment in between. So I will not go into details through all these trials, although I have the slides in my presentation, so I will skip a couple of slides to make it a little bit more easy, otherwise we go into a lot of details. But I just want to mention the first study, the Ewing 99 study. So here you can see in this study, so there are two groups, the group with localized disease, the small lesions, the larger lesions. So this prognostic factor comes back, and then the patients with lung metastasis. And the other category is the patients with bone marrow, and or the combination with lung metastasis. So these patients, historically, they received VD, so vincristine, ifosfamide, doxorubicin, and etoposide. Then surgery was performed, and then, of course, they were interested, or we were interested in the response. If there was a good response rate, patients were randomized between 7 courses of VAC or 7 courses of VI. And the C is cyclophosphamide. And here you can see the outcome of the randomization. It's published in 2014. There was no difference between both arms. But C was used to replace the ifosfamide because with this cyclophosphamide, there was less toxicity. This is published at a later moment, but anyway, the kidney toxicity was lower with VAC compared to VI. There was no difference in gonadal toxicity. So from that moment on, VAC was the standard for the patients with localized disease, good responding tumors to VD. Then we have the group of patients with a poor response. Theoretically, the lung metastases are also in this category, but in fact, you cannot draw a conclusion for lung metastasis because the vast majority of the patients included in this arm had, in fact, localized disease, but with a poor response. And in this study, the randomization was between VI and Bumel, so a high dose. And you can see that Bumel improved the event-free survival in a significant way. And from that moment on, patients with localized disease, with a poor response to chemotherapy, they did receive Bumel. And then we have the patients with metastasis other than lung metastasis, or a combination of lung metastasis with bone marrow metastasis. And these patients, they received Bumel as well. You can see the outcome of this arm of the study. And you can see that for the whole group, it's 27%. So this is the group of metastasized cases. Patients younger than 14 years, they do better. That's, remember, the prognostic factor, or the good prognostic factor. And you can have a couple of combinations. You can see here there's a mistake in this figure. But anyway, you can see if you have a lot of negative factors, your prognosis is very poor, 8%. Whereas if you have disease limited to the lungs, or your age is below 14 years, you end up with a very good, or at least a better event-free survival, around 40%. So this was the Euro-Ewing 99 study. In between, we had the Euro-Ewing, or the Ewing 2008 study. I will not go into all these details because otherwise I think it will be confusing at the end. But I come back to the conclusion. And before going to the conclusion, I go to the Euro-Ewing 2012 study, because this is an important study for the current approach. So in the Euro-Ewing 2012 study, we compared the US approach with the European approach, induction chemotherapy. And as I said already, the European approach was based on the VD courses, whereas the US approach was based on VDC, IE, etc., etc. And this was also repeated in the adjuvant setting. And here you can see that the outcome, it's published quite recently in the Lancet, that the US approach, in fact, is better than the European approach. So from this moment on, the US approach is the standard induction chemotherapy, and also for the adjuvant setting in Ewing sarcomas. The other advantage is that with the US approach, there is less neutropenic fever, so it's less toxic, and it's shorter for all stages of diseases, so also for patients with metastasis. And this is in fact the overview of our randomized trials performed over the last 25 years. As I said already, VDC IE is nowadays the standard, but from the historical studies, we know in a localized disease that VAC, I showed it to you, is better or is preferred over VI. We also we have demonstrated that there's no benefit of maintenance treatment with bisphosphonates. So this was the study in 2008. I showed you that in patients with localized disease, but with a poor response, so these are the high-risk patients, the Bumel was better than the VI. And in patients with metastasis, VI and whole lung irradiation is better than Bumel. It's less toxic because with Bumel we had some toxic deaths compared to the VI and whole lung irradiation. But anyway, VDC IE is currently the standard. So this is our European approach nowadays. Ongoing studies. So you see again the US approach. Then there is the local therapy. We always try to perform surgery when feasible. If not, it is radiotherapy. When we need a combination, then the radiotherapy is given after an additional course of chemotherapy. In the European study, nowadays, there is a randomization between a low dose and a high dose of radiotherapy. You can see there are different categories. But there is always a difference, a randomization, between 9 gray more or 9 gray less. And another thing is, I showed it already on the overview slide. In our current policy, we also randomize between maintenance and no maintenance, at least for patients with a complete remission at the end of the consolidation phase. So the maintenance is vinorelbine cyclophosphamide for an additional 5 courses. I come back on the doses of radiotherapy. But in fact, and so this was for the patients without metastasis, and this is for the patients with metastasis. I will not go into details. It looks very much to the other M0 group. So in fact, you always have to irradiate in patients with Ewing sarcomas, except for patients with a wide resection. And there's no good definition for wide resection. Some says it's 0.5 centimeters, others say it's 1 centimeter. A wide resection and a good histological response, this is the category that does not need radiotherapy. But all the rest of the patients, they need radiotherapy as well. In the postoperative setting, a dose between 45 gray and 54 gray is applied. And you see there's a wide range because during all the studies, centers were free to apply a certain range of doses. So this means that nowadays we don't have optimal dose regimens for a risk category. So for head and neck cancers, for instance, you know, if there is a rupture of the lymph nodes, you have to give 66 gray in 2 gray fractions. If there is a residual disease, you give 70 gray. So it's not the case for Ewing sarcomas. So all the protocols propose the minimum dose, but with a certain range. And the fact that the data are not available for in-depth analysis, makes it difficult for us to come to a clear conclusion. So for the definitive setting, we always recommended 54 gray to 60 gray, and for the postoperative setting, 45 to 54 gray. That's what we recommended in the past. So the study comparing the European approach with the American approach was analyzed, in particular with a focus on the local control. And here you can see the local control at 2 years. So in case of surgery and postoperative radiotherapy, the local control is 83%. So this is, for us, a good outcome. And probably in this category of patients, you can go for dose de-escalation. If you perform surgery alone, then your local control is around 80%. However, in the group of patients with primary or definitive radiotherapy, the local control rate of this most recent study was only 65%. So this means that in this category of patients, there is room for dose escalation. And we aim to improve with the new study, with the dose escalation, and we aim to obtain a local control rate around 75%. But of course, this group is biased, because patients undergoing surgery or radiotherapy and surgery, in general, they have smaller tumors, and they have tumors at less critical locations. So that anyway, there is a bias between both categories. So that's what I explained already. So in this category, we want to de-escalate, so decreasing the dose by 9 gray. And in this category, we want to escalate by adding a dose of 9 gray in a randomized way, of course. And this comes from a study performed in India. It's published 2 years ago by Laskar from Mumbai. So it was a study comparing 55 gray versus 70 gray. And you can see it's all patients with unresectable disease, M0, with a local control rate at 5 years of 76%. The outcome is significantly better compared to the 55 gray. The outcome there is only 50%. But the study is criticized because of slow accrual, and finally the study closed early. But nevertheless, I think these are unique data. And you can see by giving such a high dose, all the prognostic factors in this study disappeared. So the only prognostic factor was the fact that a high dose was given. And here you can also see that in the group of high dose, there were only 3 or 6% of local failures compared to almost 30% in the standard dose group. So surgery is considered whenever feasible. Debulking surgery is not recommended unless there is an organ compression that demands urgent surgery. So you all know the scenarios with compression of the spinal cord. In these scenarios, surgery, upfront surgery, is considered, even with an R2 outcome. You give definitive radiotherapy for inoperable tumors, and postoperative radiotherapy is performed in case of presence of risk factors. I come back on this in the next slide. And we give preoperative radiotherapy in highly selective cases only. So it's quite exceptional. We do it in cases with disease progression under chemotherapy, when complex metal implants are expected that can impact the outcome or make radiotherapy more difficult, in particular around the spinal cord. And when, but it's an not so convincing indication for pre-op when an R1 resection is expected. We from time to time consider preoperative radiotherapy as well. So postoperative radiotherapy is indicated for poor histological response to induction chemotherapy, for surgery at diagnosis, even in case of an R0 resection. So even with negative section margins, when surgery is performed at the diagnosis, we always perform radiotherapy, unless a wide second look surgery is feasible. I think the rest is clear. In case of an R1 resection with a positive section margin, or when there is an intralesional resection, you also have to irradiate. I think this is clear. And then we have some unfavorable sites that always need radiotherapy. The pelvic area, the spinal or the paraspinal area, the rib, the pleural area, the parameningeal and the craniofacial sites. Even after wide resections and a good histological response, you always have to irradiate. And also in case of a pathological fracture of the bone, you have to irradiate. And then you have the doses. I said it already, we compare in a randomized way patients with a low risk postoperative scenario. They get 45 gray or 54 gray. You have the postoperative setting, high risk. They receive 50 versus 59 gray. Definitive radiotherapy, low risk, high risk. You compare 54 gray with 63 gray, and 59 gray with 68 gray. So I will not go through all these potential indications, but the high-risk patients are the patients undergoing surgery with an R2 resection and having a tumor larger than 8 centimeters, or patients without surgery and a tumor volume with a diameter larger than 8 centimeters. So this is the highest risk category. But I think it's easy to remember. It's 9 gray, more or less between both, between all risk categories. Then for the target volumes. So in the rare scenario that we give upfront radiotherapy, your GTV is always based on the tumor extension prior to chemotherapy. Of course, when the volume has reduced, you have to adapt it a little bit. That's the reason why we call it an edited GTV, but at least the areas of contact of the tumor need to be included in the target volume. And then we add margins between 1 to 2 centimeters, of course, a little bit depending on the age of the child and the location. For flat bones, 3 centimeters is recommended. At the end, that's a lot. And you also have to take your scar from the biopsy in your CTV. When you expect motion, then you have to add an ITV. And then for the PTV, that's, of course, depending on the department policy. Here in Utrecht, we do a lot of imaging day by day. So we call it image-guided radiotherapy. So we use small margins, but in the protocol, margins up to 1 centimeter are described, let's say. But that's a lot. So this is for preoperative radiotherapy. In the postoperative setting, of course, you have to take into account the tumor extension prior to the chemotherapy and or the surgery. So in this case, it's postoperative, and the surgery as well. For your GTV, you have to adjust for shifts, of course, and then the rest looks the same. If there is a residue, then of course you end up with the third option. You have to include the scars from biopsy, but also from tumor resection in your elective dose. And then here you see the definitive radiotherapy. Again, you take into account the tumor extension prior to chemotherapy or surgery, if upfront surgery is performed. Of course, you take into account the shifts after chemotherapy. The residue after chemotherapy is also relevant because this residue needs an additional boost. And then the rest is a little bit the same. In case of a super boost, let's say, then you don't need to add an additional CTV margin for this extra boost. You can just take the visible tumor and add the margin for the PTV. So for this definitive radiotherapy, we normally split it up in 50 gray, 59 gray, and 68 gray as a super boost for the macroscopic residue. Yeah, nowadays we are very aggressive. So this means that in patients presenting with metastasis, we always try to be as comprehensive as possible. In the protocol for the radiotherapy to the lungs, it is written that you irradiate the lungs when there are remnants after chemotherapy. Here in Utrecht, as I said, we are a little bit more aggressive, and the moment there are lung metastases, we always, at the end of the treatment, offer whole lung irradiation. You can have the scenario with pleural metastasis or a malignant pleural effusion. Then you have to give radiotherapy to the hemithorax. Also in patients with bone marrow metastasis, we always irradiate the involved bones. Of course, you cannot irradiate the whole body, so you have to take this into account as well. So if there are too many bone metastasis or bone marrow activity in too many bones, then we reevaluate after induction chemotherapy, and we try to evaluate whether it is already possible in a later phase to irradiate the remaining active lesions. And then you can have, but it's very exceptional, brain metastasis in Ewing sarcomas. Well, then you have to irradiate the whole brain with a boost to the site of the metastasis. And normally we give a high dose, and we always treat them with the curative intent, at least the responding patients, of course. So the protocol is a little bit more vague for the policy on metastatic sites. I mentioned already you cannot irradiate all metastatic sites in the bone marrow. In general, we take a kind of cutoff, and we say if 30% or more than 30% of the bone marrow is involved, then you cannot propose a comprehensive treatment, and then you have to reevaluate at a later stage. So for the brain, as I said already, we give whole brain irradiation with a boost, but at the end we end up with around 50 gray. And for the lungs, we give 15 gray in 10 fractions. For children below 14 years, older children, they get 18 gray in 1.5 gray fractions. And this was my last slide.
Okay.
And look forward to your reflections and questions.
Yes, thank you, Dr. Kip Jansen. Very interesting presentation here, very comprehensive. We have a lot of insight to take from your
Stop sharing
lecture.
screen now. I think I can. Now I can see you. Yeah.
Okay. I would like to invite our two panelists, Dr. Yuni Arta, our orthopedic surgeon, and also Dr. Bambang Ari, our pediatric hemato-oncologist. The first would be for Dr. Arta as an orthopedic surgeon. Maybe it is a rare case, but sometimes we collaborate to treat Ewing sarcoma in our center. What do you have any experience or comment or question regarding Dr. Geert Jansen presentation? Please, the floor is yours.
Okay, thank you, Dr. Torana. First of all, I would like to say thank you for joining this meeting, and also it's for me it's an honor to see how to treat Ewing sarcoma in your hospital, Dr. Geert Jansen, and you can open my mind, I think, because I always give up if we have Ewing sarcoma with metastasis, and Ewing sarcoma come to our hospital sometimes with extend to soft tissue, bony Ewing sarcoma, but extend to vascular and nerve. So we think Ewing sarcoma is very challenging, but after I see what you have done in your hospital, radiotherapy has important role, I think, and also in our hospital we have a team, Dr. Jansen. The team consists of orthopedic oncology, radiology, pathology anatomy, and then also hemato-oncology, pediatric hematology, and also the radiotherapy. And we always discuss routinely every week to discuss our cases. But for Ewing sarcoma, the incidence in our hospital is not same as osteosarcoma. We have a lot of osteosarcoma patient, but for Ewing sarcoma, the incidence I think only 3 until 5 a year. And I have a question for you, Dr. Geert Jansen. You mentioned about the prognostic factor, and the prognosis factor consists of where is the location of the tumor of the Ewing sarcoma, and also the big volume of the osteosarcoma. But my question is, where is the location that has poor prognostic for the Ewing sarcoma, and also how big the volume of the Ewing sarcoma that has poor prognostic? This is the first question. And the second question is, we do wet resection. We do always wet resection in my field. The orthopedic surgeon always treat Ewing sarcoma after have preoperative chemotherapy or neoadjuvant chemotherapy, and then we continue with wet resection. Wet resection depend on the result of the MRI, but in our experience, if we have patient with Ewing sarcoma that has given chemotherapy, but the MRI after the chemotherapy is still not good. So we not sure that we can do wet resection. So sometimes we do only marginal resection. But I want to know how to manage this condition. Okay, maybe only 2 questions for me. Thank you, Dr. Chris Johnson. Thank you, Dr. Torana.
Please,
So,
Dr. Jansen, you can answer directly.
Yeah. Well, in general, we use a cutoff of 200 milliliters in daily practice, but it's not. It's a continuous variable. It's not. The cutoff, of course, is for statistical reasons. But of course, if you have a tumor of 195 milliliters compared to 500, then of course it is clear. But between 195 and 210, the difference is not so black and white. So it's a continuous variable. And in general, tumors of the pelvic region, they have the largest volumes, of course. Also, tumors of the ribs from time to time, they can grow into the thoracic cavity, and they can present with an enormous volume. These are the scenarios we see from time to time. But in general, Ewing sarcomas respond well to the chemotherapy. That's an advantage. Nevertheless, there's only a very small subgroup of pelvic tumors that will be treated with surgery. That's my experience. Although, each case is different, and we always discuss it in the team, and it's discussed at different time points. So you first evaluate after 3 courses, then after 6 courses, and the opinions can shift a little bit. So it's always a difficult decision. If the surgeon is convinced that a resection with close margins, because often it is closed, you always need radiotherapy in the pelvic area. If it is feasible, then they will, and the reconstruction is stable, they will perform it. But in general, I think the majority of the pelvic sarcomas, they get radiotherapy, definitive radiotherapy. But every case is different. If it is at the tumor is in the iliac wing, then it's very easy. No discussion on that. Each case is different. If it grows into the sacrum, then of course you always have radiotherapy as a primary treatment. I think in the Netherlands we also reflect already on the fertility issues, because this is also important at least in our population. So we have the opportunity to treat children with protons or with photons. Photons. So photons are widely available, and the disadvantage of photons is that they always give a low dose to the surrounding areas and the organs. In adults, it's not an issue, but in young children, and in particular in girls, when a low dose is given on the ovaries and on the uterus, that's an important issue. So these children, per definition, when they need radiotherapy, they always get proton therapy because of the low or the lack of dose, the low dose bed. And we also do cryopreservation of one of the ovaries for the fertility issues at long term. So maybe I'm not completely responding to your question now, but the pelvic area is a difficult area to treat, or a more challenging area to treat. Also, the Ewing sarcomas of the spinal cord are always challenging because of the dose limitations. You can go up to a dose of 52, 54 gray, but as you know, as you have seen, in fact, in definitive radiotherapy, you need 60 gray or maybe 68 gray to obtain optimal local control rates. And then your second question, can you repeat it again? Maybe I answered already part of this question, but maybe not.
Yeah. I think you already mentioned in your presentation, but I have to make sure that if we have patient with Ewing sarcoma with the MRI result after chemotherapy or radiotherapy maybe before the surgery, but the result of the MRI still, I think, still same maybe, or still extend to the neurovascular bundle and the surrounding soft tissue. So what do you advise we can do wet resection, collaborate with vascular surgeon, or still keep to do chemotherapy and radiotherapy, and then evaluate again after giving the radiotherapy or chemotherapy?
Well, we always try to stick to the protocol. So if there's no response after 6 courses, or only very limited response after 6 courses, we do not continue with the chemotherapy, because if there's no response after 6 courses, there will not be a response after 9 courses. That's in general the fact. You see a lot of response after the first 2-3 courses, and then it continues after the next couple of cycles of chemotherapy, but at a certain moment you have a kind of plateau phase. So if there is no response at the end of the induction phase, it has no sense to continue with additional courses. So then anyway the local treatment is given. So we stick really to this protocol.
Okay, it means we allow to do amputation?
Well, that's in fact then your next issue. I think it's different in Ewing sarcomas compared to osteosarcomas. If it is the case with an osteosarcoma, you will go for an amputation, probably. And in Ewing sarcomas, we tend to go to radiotherapy in these cases, unless, because we also look at the functional, we perform functional imaging with the MRI scan, and although let's say the dimensions of the tumor can remain the same, we also look at the changes in the tumor. So you can have a kind of response, and despite a similar dimension, there can be response to chemotherapy. So we take into account this effect as well. And only in the scenario that you have a suspicion of progression, it's very rare. Then we reconsider upfront radiotherapy. If it does not respond to upfront radiotherapy, then you perform your amputation. So then it's more a multi-step process. But then it's very personalized. A lot of factors interfere at that moment. But in general, we try to avoid amputations in Ewing sarcomas.
Okay, thank you. Thank you, Dr. Jansen, for your explanation. Yeah.
But then again, it's not a black and white story.
In the next time, I hope in the next time we can discuss.
Reflex comes with arguments. You listen to the patient, because the patient can also share his ID on this disease. In fact, there are only biased analysis. As I said already, in theory, surgery is better. But the publications are always biased because you irradiate, you operate the small tumors and tumors that are easy to resect. And all the complex cases are treated by radiotherapy. So it's a mix of prognostic factors, poor prognostic factors in this group.
Thank you.
Okay, thank you for the discussion, Dr. Arta and Dr. Kia. Next, we have our hemato-oncology, pediatric hemato-oncologist, Dr. Ari. Maybe you have some experience treating Ewing sarcoma, or do we have a necessary tool in our hospital or our country? The Dr. Kids says that we need to approach with US protocol, and then and also we do the maintenance phase. Do we have the tool for that, or what is your experience, or maybe you have comment and question regarding Dr. Kier presentation? Please, the floor is yours.
Thank you, Dr. Rana, for this very kind opportunity, and thank you, Dr. Jansen, for sharing your insight regarding the treatment of children with Ewing sarcoma. Yeah, we have a lot. We have not many patients with Ewing sarcoma. In our registry, we have less than 20 patients with Ewing sarcoma within the last 5 to 10 years. And we are now adopting the protocol, the chemotherapy protocol, the US version from the COG, in which we give the ifosfamide, cyclophosphamide, vincristine, and etoposide. But the problem is that most of our patients, maybe more than 80% of our patients, came in metastatic, and most of the patients were in the malnutrition status. So it is our we hypothesize that the situations of the malnutrition may increase the risk of myosuppression in our patients. And sometimes you have to postpone the administration of the cytostatics. And sometimes also we have to reduce the dose of the cytostatics. Dr. Jansen, do you have some suggestions or opinion if we are postponing the administration of the cytostatics, or we reduce the dose of the cytostatics? Will you modify the dose of the radiotherapy in these settings?
Can you repeat it a little bit, because I there was some. So you can you repeat your question, because I missed part of
Okay.
of the sentence. Yeah.
Yeah. Since sometimes you have to reduce the dose of the cytostatics, the chemotherapy, and sometimes you have to postpone the schedule of the chemotherapy.
Yeah.
Then do you have any suggestions regarding the dose of the radiotherapy? Should it be modified as well or not?
Well, ideally not. I think you have to give your radiotherapy within a limited time. So we know from a lot of diseases, in particular medulloblastoma, for instance, that overall treatment time impacts the outcome. So I think it's very important that the total dose is given within the foreseen time period. And I think it becomes more and more important when your chemotherapy is not given in an optimal way. So I think that, of course, radiotherapy cannot compensate for everything, but I think if your chemotherapy is interrupted more frequently because of the frailty of the patients, then this has an impact on your overall survival and also on your event-free survival. So the only thing you can hope is that the radiotherapy is given in the foreseen 6 or 7 weeks or so, if it is definitive radiotherapy. Yeah, I think it's very important.
Yeah, thank you.
because the US approach is every cycle is given every 2 weeks. It's even more compact.
Yeah.
So the overall treatment time is very important in Ewing sarcomas.
Yeah. Thank you very much for your suggestions.
Okay.
Yeah,
Thank
I
you,
think,
Dr.
and you said 80% of your Ewing sarcomas are de novo at presentation metastasized.
Yeah.
Yeah, that's a little bit different compared to our situation. As I mentioned in the slides, here it is around 25%. I think access to specialized care is a little bit easier here. That's what I think. Yeah.
Thank you, Dr. Kir. Dr. Ari, do you have any more question or comment maybe?
Thank you, Dr. Torana.
Okay. Me as a radiation oncologist also have a few questions if you don't mind, Dr. Kir.
Of course.
The first would be when you mentioned before that for post-operative radiation therapy, do you use pre-chemo or pre-surgical? If it is resectable after chemo, you still use pre-chemo or in the initial volume at diagnosis or after the chemo but before the surgery? That's my first question. And the second will be about the whole lung irradiation. You mentioned that you radiate the remnant of the lesion. What do you what imaging do you use to decide it is a remnant or not? Is it a CT or a PET CT to you in your decision making? And the last question would be if sometimes, as Dr. Ari mentioned, sometimes we have to tackle the condition like malnutrition and also hematological consideration like low blood count, and that can delay chemotherapy or sometimes a radiotherapy. Do you have any problem in your center? And what is or do you stick to the plan? Is how low do you propose that we stop and delay radiation if it is high volume radiation like bone site, spinal site that is frequently can compromise the blood count? Or when do you continue? How many blood count do you need to continue radiation? Maybe that's all my question.
Yeah. Okay. So we have question on the lung, the volume, and the malnutrition, and the blood values. Yeah. Okay. So for the lungs, we always give whole lung irradiation, and if there is residual disease, we apply a simultaneous integrated boost. So during the whole lung RT, we give an additional dose on the macroscopic lesions. And the macroscopic lesions are defined by the CT scan. So we perform a high resolution CT scan. The PET scan is performed, of course, a diagnosis and at interim as well, but not specifically for the lung metastasis. We don't need the PET scan for the lung metastasis because the lesions quite often are so small that you cannot find them purely based on a PET image, and it's based on CT scans, on a high resolution CT scan. So, but we always combine whole lung irradiation, and we don't give radiotherapy to the metastasis side of the 1 or 2 or 3 metastases only. We give always a whole lung RT with a boost when there is visible disease. Yeah. So that's the first issue. For the volume, Yeah, I think you always have to take into account the extension of the tumor at first presentation and not at the time of surgery. So this means you always end up with a large volume. That's a fact. Yeah, you don't have to limit your. Yeah, imagine you have a very large tumor, and at the time of chemotherapy of 10 centimeters, and at the time of chemotherapy it's only 2 centimeters. No, you don't have to irradiate the 2 centimeters. You have to irradiate the 10 centimeters. Even when the 2 centimeters is resected by the surgeon, you really have to take the upfront situation in your volume.
Okay,
But you can give a low dose to this part. You can use a kind of countdown for your dose and give a low dose, an elective dose to the initial volume, and then come up or end up with a larger volume or larger dose on the small volume. That's how we tackle this problem normally. So you use different planning target volumes with different doses depending on the risk. And then the initial presentation is the elective dose, the lowest dose area. That's how we do it.
So
and then concerning you have a question on that?
Yeah, so if we have a large volume at presentation, maybe 15 centimeters, and post chemotherapy we only have 5 centimeters, then we can give the 5 centimeters is more definitive dose, and the outer part can be given 45 maybe, or 50.
Well, let's say the elective dose receives, depending a little bit on the risk. Is it a poor response? Are the section margins free? All these things are relevant. But your, let's say your largest volume needs a dose of around 45, 50 gray. And then depending on the other characters, how big is the tumor? Are the resection margins positive? Is there macroscopic residue? You end up with the dose up to, in the study we go up to almost 70 gray nowadays, 68 gray. But this is a study question. In general, most people out of studies end up with 60 gray or 59.8 gray, something like that, when there is residue visible.
All right. You want to mention something?
But at least you have to give 45 gray to this area at initial presentation.
Okay, at least 45.
At least 45, yeah, that's the minimum dose.
Thank you.
And
maybe
then concerning
the
malnutrition and the blood counts, well, yeah, it's exceptional that radiotherapy brings the patient in, let's say, a neutropenic situation, at least for an Ewing sarcoma. We have these scenarios with medulloblastomas undergoing craniospinal axis irradiation, but it's exceptional. Even if we irradiate several metastatic sites at the same time as the primary tumor, of course we control the blood cells, the platelets and the white blood cells, but you never end up with a neutropenic situation only due to radiotherapy. And the chemotherapy is also a little bit adapted during the radiotherapy. That's what you know. Some drugs are not combined. You never combine actinomycin and doxorubicin with your radiotherapy. So I never had the situation that the patient, had blood or platelets below 20,000 or so, or 20, during radiotherapy for a Ewing sarcoma. If this is the case, then you have to give a transfusion. That's what you have to do. But anyway, you have to try to avoid interruptions. because of the prognostic factor of
Right.
a larger or a longer overall treatment time. Yeah. Yeah, and malnutrition, we don't have these problems here in the Netherlands, because from the beginning, our dietitians, they are involved, and they a lot of children, they have tube feeding, so we don't have this as an issue for radiotherapy. Of course, up front it happens that the child has malnutrition, but from the beginning they are supported by the dietitians.
So since the start of chemo,
But I can imagine that with
are
more
reaching-
metastatic disease or more metastatic cases, that this is a real issue. I can imagine that. Yeah.
Yeah, especially tumor in the abdominal cavity, maybe it will compromise with the nutrition.
As I said, they have tube feeding, but in addition to that, we have a lot of, in case of an abdominal location, because in my opinion, for a pelvic tumor, the tolerance is quite okay, at least with all these modern techniques. I don't see a lot of nausea and vomiting. But in case of, we have a lot of medications options to give to support the patients during the radiotherapy.
All right.
With dexamethasone as the heaviest drug against nausea, but normally it's not such a big issue here.
Okay, thank you. Okay, Dr. Kier, maybe we still have some question from our participant. If you don't mind, maybe we still have 5 minutes.
Yeah, no problem.
Yeah, there is a question from Dr. Lucas Topping. In the chat box, you can also see that the first question is there a place for immunotherapy in the treatment of Ewing sarcoma with metastasis? And the second, are all Ewing sarcomas manifest with onion skin appearance? If not, does it prompt us to do karyotyping? Okay, thank you. Please.
Yeah. Well, maybe there is a place for immunotherapy, but it's still a study question. We don't know at the moment. It's not standard of care, but probably. But I have seen a couple of responses with immunotherapy, but it's not standard of care. It's still a study question. So in the future, maybe yes. Yeah. And are all Ewing sarcomas manifest with onion skin appearance? No. No, that's a typical image, but not all the Ewing sarcomas. Yeah. From time to time, it's impossible even for the radiologist to distinguish an osteosarcoma from a Ewing sarcoma. That's the reality. Yeah. That's a typical image that you see in the school books.
Okay, how about the karyotyping? The question, the follow-up question.
I don't think so. Yeah, I think if you perform your biopsy, you have your typical features. I'm not a pathologist, but I think CD99 is typical for Ewing sarcomas, and you have your typical translocation. If you have this translocation, I think even in Indonesia, you look at these translocations, or is it purely based on staining?
As far as I know, we have basic staining and also immunohistochemistry, but for the the translocation, it is not for a lot of disease, maybe some disease we have, but I don't think Ewing we have, but us or pathologists.
Yeah.
Yes, but
Yeah.
I think Ewing is enough for just for basic morphology and immunohistochemistry, right?
Yeah. But yeah, you know, we have access to all these molecular, fancy things. So we always have 100% confirmation by all the molecular stuff. But in fact, historically, we have always treated Ewing sarcomas without molecular information, just based on the typical image on the X-ray, the age of the patient, and small blue round cell features, and then some immune histochemistry. Yeah. So you don't need it, but it's for us the confirmation that it's not another exotic subtype of small blue round cell tumors.
Yes, and we don't differentiate the risk according to the profile. Right now, we don't differentiate like any other, maybe medulloblastoma or so the treatment will basically the same regardless the immunophenotyping or
probably
some other
yes. Yeah,
feature.
even if
Yes.
it is a rare subtype of bone malignancy, small blue round cell tumor. Yeah, probably there is not a personalized protocol at that moment. No, all right.
Yes.
Yeah.
Okay. Thank you. Okay, thank you. It's very insightful discussion we have this evening, but I'm sorry that I have to conclude our session today because it's already 70 past 30 in Indonesia. Maybe in Urtai it's already maybe 12 o'clock. Okay, thank you again, Dr. Jansen, for your kind presentation and discussion. Dr. Yuniarta for your collaboration and also your insight on the surgery, and also Dr. Ari for your valuable information and also question for to deeply understand our management in Ewing sarcoma. And I would like also thank to all participants that participate actively in this discussion. Thank you very much. I would like to close this webinar. Once again, thank you very much. See you in another webinar. Maybe Dr. Kirby can consult you some other time if you don't mind. Okay. We also have collaboration with Maxima, the Maxima Dr. Who is Dr. Ari? You may mention our colleagues in Maxima that already come to our hospital.
Judith Spekerman.
Dr. Judith, if speaker plan, and Dr. Bianca also contact.
I know.
Yeah,
them
Dr.
personally,
Bianca.
of course. Yeah, I know.
Yeah. Okay. Yes.
So it was nice to meet you.
Yeah, nice to meet you too. Thanks for happening. Thank you very much. Bye.
Bye.
Maybe Dr. Eka, you can conclude, or maybe is there any announcement?
Yes, thank you, Dr. Torana. We would like to thank you to everyone for doing our webinar today on Sarcoma. Also, thank you, Jansen, for being our distinguished speaker, and to our panelists, Dr. Yuniarta and Dr. Bambang. Also, thank you for our moderator, Dr. Torana, for guiding our discussion. We hope you all found today's webinar valuable. And also, don't forget to begin your lesson on pelataran sehat immediately to ensure you receive the FK-KMK credit. Please remember, the lesson is only available until midnight today. We also look forward to seeing you next time. Stay safe and keep up the great work. Goodbye and see you next time.